The Belding H. Scribner Award is presented annually to one or more individuals who have made outstanding contributions that have a direct impact on the care of patients with renal disorders, or have substantially changed the clinical practice of nephrology. Established in 1995, this award honors the physician who developed the arteriovenous shunt that first made long-term hemodialysis for chronic renal failure possible. In this episode of the ASN Kidney News podcast, I speak with 2010 recipient Hans Henrik Parving, MD, as well as the first co-recipients of the Scribner Award, Jack W. Moncrief, MD, and Robert P. Popovich, MD. Dr. Popovich, can you recollect what it was like to work side by side with Dr. Scribner, and also how you felt about receiving an award that was named in his honor?
It was like a dream come true. I've always had the greatest respect for Dr. Scribner, having worked with him. It's a pure joy. We would have these meetings of engineers, clinicians, and he would come walking in, usually late, and it's like a fresh air came in. And he would listen for a few seconds what discussion was about, and then out of his mouth would come wisdom. Pure joy. To me, receiving that award was the greatest thing in my career. And then when I show my friends my awards, it's the first one I go to. But then I've been very fortunate to have worked with Dr. Scribner and Dr. Moncrief. Get a bunch of bright people together, it's amazing what can happen.
Dr. Moncrief, you and Dr. Popovich were the first recipients of the award. Please tell us about your career as it led to the Belding Scribner Award.
Well, we were, I think, both very surprised to have been the first recipients of the award named for Dr. Belding Scribner. Of course, we were flattered, and it was, I think, one of the highlights of my professional life. But we felt like that there was a recognition that there was another way that dialysis could be done in managing patients with end-stage kidney disease. When I arrived in Austin back in 1969, there was no dialysis in the capital state of Texas. There was no dialysis carried out. So I got in on the ground floor of the initiation of a dialysis facility here, and a young biomedical engineer graduated from the University of Washington. His name was Dr. Robert Popovich, and he came to Austin to set up the biomedical engineering department here at the University of Texas. And since I was the only nephrologist in Austin, I was fortunate enough for him to come by and say, hey, Jack, would you like for us to work together? And it was a very fortuitous event in which a patient presented to me with end-stage kidney disease from type 2 diabetes, interestingly enough. I, like Dr. Parving, had noticed that the community of Austin was flooded with patients who were ill from reaching kidney disease and then end-stage kidney disease from diabetes. And there was really nothing that I had to offer as a nephrologist except dialysis, and we did not accept patients for dialysis at that time who had type 2 diabetes because it was felt by the general nephrology community that these patients would do poorly with dialysis. And I even set up a death committee, which was first described by the Washington group and published in Life magazine, showing that there were a group of people in a community who would come together and help the nephrologist decide whether or not a patient should be offered dialysis or not. In those days, there was no money for dialysis. The Medicare payment for dialysis didn't come in until 1973, and when I arrived in 1969, 70, 71, 72, for those 4 years, there was no government or economic support for dialysis. And so the eventful development of a new procedure, which was less expensive than hemodialysis, at-home hemodialysis, that is, CAPD, a fortuitous event when I presented to Dr. Popovich and his students a patient who I could not establish a vascular access on. Every time I did, for 7 separate surgical procedures, the patients clotted the arteriovenous access. So this patient was about to expire from end-stage kidney disease when the concept of CAPD came out of that scientific meeting. And I feel fortunate not only to have dealt with Dr. Popovich over the years and to have seen exactly what Dr. Parving has just finished describing, the development of the capacity to do something about the majority of patients who develop progressive kidney dysfunction, those associated with type 2 diabetes. Now I have in my treatment bag a therapy which I am personally experiencing as a miracle in the management of these patients. So I feel very fortunate to have been in on the ground floor of the development of nephrology in Austin and I think somewhat in the United States, and with the aid of Dr. Popovich throughout the world with the development of continuous ambulatory peritoneal dialysis. And I felt like the recognition by the nephrology community in the form of the Belding Scribner Award was a wonderful thing for me personally.
Dr. Parving, you're the 2010 Scribner recipient. Please tell us about your career.
I graduated from medical school at the University of Copenhagen in '69. I went directly into science. I was employed at the Department of Clinical Physiology, and my task was to develop a method for measuring permeability of large molecules in human beings. And I used a couple of years of my life trying to do that, and I was pretty unsuccessful. And I was actually at a moment of quitting, but a good friend of mine persuaded me to give it another go. And a month later, we actually had a method which we could measure permeability of albumin, IgG, and even larger molecules in human beings. And ever since I've been in science, I then graduated or had my doctoral thesis a couple of years later, and that was dealing with hypertension and diabetes and the pathogenesis of these two conditions causing vascular damage. Then I went into endocrine diseases. I was trained as an endocrinologist. I became the chief physician at Steno Diabetes Center in '83. I became professor in '97. Then worked at Steno nearly for 25 years, and in 2007 I moved to the National Hospital of Denmark, which is a huge hospital with 2,000 beds, the biggest one we have, and I'm professor at that institution nowadays.
Dr. Parving, I'd like to take advantage of the benefit of your 40 years of experience and ask you an expansive question. How has the care for patients with kidney disease changed?
The care for kidney disease has changed immensely. It's nearly a revolution. I remember vividly when I finished my doctoral thesis in '75, I was working at Steno, which is a small specialized hospital owned by Novo Nordisk, which take care of diabetic patients. And the hospital in those days was flooded by young people who waited to die from uremia. We had no treatment tool how to prevent the disease. We had no treatment when they developed overt proteinuria. And finally, when we needed assistance from our friends within the Department of Nephrology in Copenhagen, they did not offer diabetic patients dialysis, mainly due to the fact that many of these patients was already having had a stroke. Many of them was blind or severe visual impairment. They have MI, they have heart failure, they have amputation. There was just poor life left to die. And in the same year, actually, Dr. Kussman from the Joslin Clinic in U.S. wrote a paper in JAMA where he stated that diabetic nephropathy is irreversible in humans. There are no cure, there are no treatment. There's a relentless decline in glomerular filtration rate towards death. And on average in those days, the average survival was between 5 to 7 years. And then half of the patients had vanished from the earth. So that was the outlook in those days. And what I actually was interested in, I was interested in hypertension and to a less extent in diabetes. But my interest in hypertension then brought me to try to treat blood pressure in patients with diabetic kidney disease. And in the old days, we used beta blockers. We used always a diuretic because they had fluid and sodium retention, and we used hydralazine. And we published the first data in 1983 in the Lancet, where we could describe that we was capable of lowering blood pressure in type 1 patients who have diabetic kidney disease. It lowers also albuminuria. More importantly, however, the drop in kidney function measured by an isotope technique went down from nearly 11 milliliters per minute per year to less than 3. And further on, we could demonstrate that this beneficial effect on progression was improved by prolonging the treatment with blood pressure lowering agent. So improved output was actually observed. Furthermore, we could also demonstrate that approximately half of the patients receiving aggressive blood pressure lowering treatment had a drop in kidney function around 1 milliliter per minute. And one has to remember that when we started this kind of treatment, the general concept was that you should be very cautious by lowering blood pressure, and blood pressure usually causes ischemia, and that was a dangerous situation to lower it too much. However, as you all know, Barry Brenner in his animal experiment suggested that there was actually hyperperfusion and increased pressure within the glomeruli, which was the driving force, and I'm a very strong believer in that concept. Anyway, a couple of years later, in 1986, the first demonstration came that lowering blood glucose by using insulin pumps could actually postpone the development of microalbuminuria. Microalbuminuria had been described already by us and John Carlo Viberti from Guy's in 1982, and that was actually a pre-runner of diabetic kidney disease, so we have the opportunity now to postpone the disease. At the end of the 80s, we had the first long-term data dealing with blood pressure lowering treatment, which have demonstrated that the life expectancy, instead of on average in Copenhagen being 7 years with diabetic nephropathy, now has gone up to 14 years, so that was a major step ahead. In the year 1991, the first large study was carried out showing that by use of ACE inhibition, you could actually prevent the occurrence of diabetic kidney disease in type 1. That was a study we performed for 8 years, and we could also demonstrate in that study, published in the British Medical Journal, that we could preserve a kidney function, and that's of course what is really matters. 2 years later, the important studies was published. The DCCT trial was published using intensified glucose lowering, and they could demonstrate that not only development from normal to microalbuminuria, but also from micro to overt nephropathy could be slowed by improved glycemic control. And in the same year, Ed Lewis and his co-workers in the Captopril study group demonstrated that blood pressure is good, but blocking it with Captopril is even better. So there was this additional information about ACE inhibition. A couple of years later, I think the most important study ever published in diabetes was published by Michael Maurer and his co-workers dealing with pancreas transplant. It was 1997, where they published a paper in New England Journal of Medicine of the experience of 10 years of successful pancreas transplantation, where the patient had been without insulin for 10 years because the pancreas worked perfectly all right. And what Mike could demonstrate in that study, he had biopsies at baseline, he had biopsies at 5 years and biopsies at 10 years. He could demonstrate for the first time ever in human beings that structural lesions, which looked nasty, meaning Klinefelter-Wilson's diffuse and also nodule, could actually reverse, could go back, or in other words, that we have the first really clear evidence that what is going on in the kidney, at least in diabetic patients, is a reversible process. This is a dynamic process with synthesis and degradation, so that was really a major step ahead. A couple of years later, we was lucky enough, together with Ed Lewis, to demonstrate that we could introduce a concept called remission and regression of diabetic kidney disease. We looked at patients who had more than 3 grams of albumin and looked at the possibility of lowering it to less than 500 milligrams, and that actually occurred in 1 in 3 of our patients, and those who had the benefit of such a huge lowering of albuminuria had a much, much better long-term prognosis than those who did not obtain that. A couple of years later, we also had the luck of demonstrating that even low-protein diet, even though it's cumbersome and difficult to change people's lifestyle, actually had a beneficial effect on end-stage renal failure and death. And finally, in the year 2005, we had a follow-up study from our institution published in KI, where we could demonstrate that, at least in our hands, the survival in type 1 patients with diabetic nephropathy has improved from 7 years to more than 21 years. So there have been a major improvement in the outlook for these young people. So all in all, dealing with type 1, you can say that improved glycemic control is beneficial right on. Blood pressure is lowering is a very good tool. Lowering by using blockers of the renin-angiotensin system is definitely preferable. And finally, the difficult one, low protein diet works, but it's very difficult to implement because people don't like a change in lifestyle. The reason why I do it this way is the following. Diabetes in the old days was always type 1 diabetes. People didn't care about type 2. It was that disease which was have no impact actually on the scientific community. It was of little interest, while nowadays it has changed completely. So the type 2 is now dominating.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. The information in this podcast should not be used during a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.